postdoctoral research. It's just starting now, so I'm not presenting you any results at this point, but I'll give you a lot of background on the research that is shaping my research questions and how I'm planning to do my study. So I'll give you this background of what we already know, what we're trying to find out, and then how we plan to get there. So to give you some background on women's health, women living with HIV in Ontario, the majority of people living with HIV in Canada actually reside in Ontario. In 2017, we had 881 new HIV diagnoses in Ontario, and here on this graph you can see the rate separated by the sexes. The rate of new diagnosis is generally lower among women, and it's consistently 3 to 4 times higher among men. Since 2014, we have a very slight increase in women and in men, where the rates were 1.9 and 9.7 per 100,000 people respectively. And the HIV diagnosis of women in Ontario has been, as a proportion of new diagnoses, has been steady at about 20% for the last decade. What's important to note is that about 80% of women living with HIV are of reproductive age, so they're generally younger. Here I'm illustrating you who is most at risk of developing HIV among women in Ontario. When we look at all people when we look at the general population, it is the people who are most at risk of getting infected with HIV are people who are gay, who are bisexual, men who have sex with men. But among women, this is of course a little bit differently. Here our highest proportion is among African Caribbean blacks, followed by people who inject drugs, and then by indigenous people. Even though men are more likely to get infected by HIV, women are particularly vulnerable to get infected, and this is a biological and structural reasons. Women generally are more likely to live in poverty and are affected by the social determinants of health in Canada. And there's a strong link between the social determinants of health and getting infected with HIV. Between 2011 and 2012 and 2015-2016, we see the rate of new infections among African Caribbean black slightly decreasing, while we see a slight increase among people who use drugs, and also among indigenous people. Now, why this is relevant to the research that I'm proposing to do is that women living with HIV are intending to have children. So this is kind of a newer phenomenon. When women started to become infected with HIV like decades ago, this wasn't the case. They were told they shouldn't have children, and just by the kind of drugs that they had to use, they were not fertile often enough to get children. But nowadays, when people are treated continuously with antiretroviral therapy, their life expectancy is very similar to that of the general population. For women, if they are continuously treated with antiretroviral therapy, their fertility is actually increased, so they have an almost normal level of fertility as women who don't have HIV. And their HIV transmission risk during unprotected sex with their partner, if their partner doesn't have HIV, is actually extremely low. So it is possible to have children that way. What is also interesting is that breakthroughs in pregnancy care have made the transmission risk of the HIV being transmitted to the infant during pregnancy or birth to be less than 1%. So it's a very low chance that if the woman is well treated throughout her pregnancy with antiretroviral therapy, that the baby will get infected. So as we see in this graph, it's kind of a busy graph, but we can see that women are planning to become pregnant and to give birth. Between 2007 and 2009, there was a survey that was answered by 490 women living with HIV in Ontario. It was called the HIV Pregnancy Planning Questionnaire. And they assessed fertility desires, any intentions, and also actions of women living with HIV and wanting to give birth. And they found that 69% of women living with HIV currently in Ontario are intending to give birth, while 57% strongly expect to give birth in the future. So it's a high percentage. And correspondingly, we also see that the rate of infants born to women living with HIV in Ontario is rising. While in 2001, there was 53 infants born to women living with HIV. In 2011, it was 101 infants. Now, we don't actually have any newer data on that. The latest data I could find was from 2011. So, and this, of course, is interesting for my study, that this is the gap that I can fill to get some newer rates on this. So this figure here I show you the HIV prevalence rate among women living in Ontario between 1999 and 2011. They had identified 771 pregnancies where the mother had HIV. And what is interesting about this is that about half of these women who were identified as having HIV during their pregnancy were newly diagnosed either during their current pregnancy or during a previous pregnancy. Now, Ontario has a policy that women are automatically tested for pregnancy for HIV during pregnancy, unless they say they clearly don't want it. So almost all women in Ontario are tested for HIV when they become pregnant. And the other half of these women had been diagnosed with HIV previous to their pregnancy and outside of pregnancy. What we also see, we see this pretty sharp increase, which we aren't sure about what is going on yet. The prevalence rate had gone up from previous years to 0.64 per 1,000 pregnant women. And given improvements in antiretroviral therapy since then, I'm very interested to see how this rate has changed more recently, because again, we don't have newer data on this. Now, what used to be recommended when women who were pregnant and living with HIV, they were recommended to give birth by C-section to further reduce the risk of transmitting the HIV virus to the infant. Now, C-section is a cesarean section. It's a great procedure. It can save lives in medical necessary situations, and especially in our Canadian well-equipped hospitals. But it is a surgery that is associated with other risks. And those are risks to both the mother and the baby. And especially among women living with HIV, they have a compromised immune system, so it can actually further greaten the morbidity of these women if they have procedures that might not be necessary for them. Now, in 2007, the World Health Organization, they launched it's called the Consolidated Guideline on Sexual and Reproductive Health and the Rights of Women Living with HIV. Now, it's important that this is a guideline. This is, of course, intended for the whole world. So they make recommendations as much as, for women living with HIV in Ontario, as women living with HIV in Kenya. So this has to be taken into account when we interpret these recommendations. But what is very interesting is that they actually recommend nowadays that women who are treated continuously with antiretroviral therapy throughout their pregnancy should not give birth should not routinely give birth via cesarean section, only on the basis of having HIV. So these women should still be offered a cesarean section if it is medically necessary, but it shouldn't be the routine procedure, because they actually haven't found that it makes a big difference on the transmission rate of HIV to the infant. This guideline takes a women-centered approach throughout, and they reviewed lots of evidence. And Mona Lautfi, the woman who leads the CHIVO study, who we are collaborating with, she was one of the collaborators on this guideline as well. So now to summarize a bit of what I've been just bombarding you with, is that there's a high number of women living with HIV in Ontario who are of reproductive age. These women are increasingly intending to become pregnant, and they're increasingly giving birth to children. We see there was an increase in rates. But we only have rates until 2011. The risk of HIV transmission to the infant is actually very low if women are well treated throughout their pregnancy. And these women can give birth without extensive medical procedures unless they have other medical problems, just like any other woman. So thereby we can further reduce their risk of morbidity if we don't make them use other kind of procedures that they really don't use. What we currently don't know, though, is how these women use the healthcare system throughout their pregnancy and while giving birth. We don't have data. We have data on this in Ontario, but it's not publicly available yet. I haven't found any studies that are more recent on this. And we don't know the health outcomes following pregnancy and birth. So for my postdoctoral research, I'm planning to fill these gaps. And I'm planning to first describe what are the patterns of healthcare use among women who are pregnant and giving birth and who are living with HIV in Ontario. So specifically, I want to look at the rates of prenatal screening, the types of maternity care provider they're using. For example, are they always an obstetrician, or do they also use family physicians or midwives? What kind of prenatal care do they receive and how often? What kind of screening do they use? And the location of prenatal care, where they deliver, and with this I mean both in a location within the province, but also is it always hospital births and always high-risk hospital, like what level of hospital. I want to look at their use of antiretroviral therapy and any kind of labor and birth interventions that they might be having. Then secondly, I'm planning to assess the health outcomes and determine the rate of poor health outcomes among pregnant and birthing women living with HIV in Ontario. Here I'm planning to apply the Canadian perinatal surveillance system's definitions of severe maternal morbidity, and this includes things like flat font fusion, postpartum hemorrhage, hysterectomy, cardiac arrest, and eclampsia. I'm probably, initially I was going to also look at maternal mortality, but the rates will probably be too low to make it meaningful, so I doubt I'll be doing that. There's currently no research out there that compares the maternal morbidity among women after following a cesarean section that compares women living with or without HIV. And so I plan to fill this gap with my study. And then I thirdly plan to evaluate the patient characteristics that are associated with poor maternal health outcomes, because this research needs to have meaning and needs to be able to be applied by the decision makers. So with this third part, I can hopefully show who is mostly at risk for poor birth outcomes and how could we possibly intervene. So now, how am I planning to do all of this? For the first parts of my study, I'm planning to use linked administrative data from the Institute of Clinical and Evaluative Sciences. And this is fantastic because I'm collaborating with Dr. Claire Kendall, who's a scientist with ISIS and has lots of experience using their data. And so using this kind of data, I plan to describe the women's healthcare use and their health outcomes. I will probably compare this service use and health outcomes of this cohort of pregnant women living with HIV to a 5 times bigger cohort of women living without HIV, because it's interesting to describe what are their health outcomes and what kind of services are they using, but it makes it more meaningful to compare it to similar women but who are not living with HIV to see if there's any differences. Now, to evaluate the characteristics that might be associated with poor health outcomes, we are linking the data from the Canadian HIV Women's Sexual and Reproductive Health Cohort Study to the linked data, to the administrative data at the Institute of Clinical and Evaluative Sciences. And to be able to get richer data and to fill this gap, this cohort study, SHIVOS, it's run in Quebec, in Ontario, and in British Columbia. They use interview administrative questionnaires. What is really unique about them is they all of the data is collected by peer researchers. So all women who have HIV who are answering the questionnaires are interviewed by other women living with HIV. And this is fantastic because you might get richer data, more honest answers, better understanding, and both sides can better explain things to each other. But the other important thing is that these women the women peer researchers have been able to reach more hard-to-reach populations, so women that usually wouldn't be part of studies. They have disproportionately tried to include Indigenous women, young women, so women under 30, and trans women as well, which isn't as relevant for my study, but it's very relevant for the study in total. The primary objective of this SHIVO study was to investigate the concept of women-centered care in relation to HIV care. And with this questionnaire, they have amazingly rich social variables. They ask about incarceration, for example. We get more detail on the indigeneity, which I wouldn't get just from ISIS data alone. And it also includes more attitude questions, like the perception of stigma within the healthcare system, And it also gets at gender roles and gender identity. So these are all things that I can then explore if this has a relationship to poor maternal health outcomes. So this study I find is important as the first evaluation of maternity care service use and health outcome among women living with HIV in Ontario, and to update all their data and to bring a richer light to it. I'm very hopeful that my research will identify factors that are associated with poor health outcomes and areas to improve maternity care for this vulnerable population of women. So I really hope that we can better intervene in the future with more of these women giving birth now in Ontario, to make sure that they have the best birth outcomes possible for themselves and their infants. And this concludes my presentation. Any questions or suggestions? This is an in-progress study. Yes, Kevin?
Thanks. Yeah, no, that's really exciting, and I think this is important work. Do you have any idea what numbers you're going to be working with? Because that'll be really important in determining like various like subgroup analysis and things like that. Just curious if you have any idea.
Right. So the SHIVO's data for Ontario is 800. 813 women have answered the questionnaire for SHIVO's in Ontario. It's 1,400 across Canada. So I'll definitely get that number. Not all of these women are sexually women, so some of those would be trans women. I don't know that rate yet though, so it would be a fewer number of women that I would be linking to the ISIS data for the purpose of my study. So that's about it. So it's not huge, but it's important.
Thanks.
Thank you. Yes, Doug?
Yeah, thanks, Esther. That was great. And as a medical sociologist, I can see that this would be very interesting to you. But as a medical sociologist, I would also think that relationships are something that you're very interested in as well. And I can sort of see that linking these two data sets is going to provide you with some rich information, right, that could lead you to explore relationships amongst not only the women who are pregnant, right, but also once they give birth, right, sort of postpartum relationships and supports that form. I was wondering maybe if you can possibly speak to what these supports may be, how they may lead to relationships, and how that may have an effect on health outcomes in the future.
Right. Well, so what I would be looking at is relationships to healthcare providers. They do have questions on how stigmatized do you feel, and they don't ask it this way. They ask it in a way that gets at this idea of how stigmatized do they feel within the healthcare system, without using these kind of weird words. So that will be, I find that very interesting to explore, and I wish I could explore it in comparison to women without HIV, because I don't know. Like, of course, its stigma is very much related to HIV, but I can't, any of these social variables, unfortunately, I cannot compare, because this cohort is only among women living with HIV. So that's a downfall, but it will be very interesting to explore how these women relate to their healthcare providers, how often do they go? If I see a difference, then maybe with the SHIVO's data I can find out why I might see a difference, that they might not seek prenatal care as often or as early already in the pregnancy. So that will be very relevant. Among relationships within the greater social context, that's a bit difficult to explore this using administrative data. I don't want to make false projections. I don't think I can really go there with this data at this point. But I would be able to see in which areas these women are located and where they're giving birth. So there might be something there.
So a suggestion could be that, I mean, it might not end up being work that you do, but when you were contextualizing the findings, right, SHIVO's has a community advisory committee, and it would be good to work with them to explore maybe if that was something that came up. But even, I don't know if SHIVO's has questions on social support. I bet they do somewhere in there, stuff on social connection, right? And maybe looking at even things like vaccine rates in their children, or easy, in the first year of life, or something like that, or. And it might be, again, not something you do, but something that could be explored, and then something that could be explored more qualitatively with the community. Yeah,
that's right. Yeah, yeah, I'm staying away from qualitative research with this right now. I have a background in this, and I've done it for a PhD now, but this is a short postdoc.
Gotcha.
And I want to dig my teeth into the ISIS data. I'm excited about that. I have to
Very good.
Yeah.
Did you say short and ISIS in the same sentence?
Compared to qualitative? I don't know. Yeah.
I just have one more question.
Yes.
One thing that I thought about as you were speaking is, do you remember what the proportion of Indigenous women is in GWAS data?
I don't know the proportion for Ontario, no, but it's high. It's a high proportion.
Just we may need to think about ISIS data because it doesn't capture. I don't know. We need to look into that. Whether which data sets, like some of those mom baby data set may include Indigenous women, but otherwise sometimes their care gets captured outside. So especially with something like Deepak and
absolutely. Thank you. Yeah. Otherwise, the nice thing is that I can identify who is Indigenous, which otherwise I couldn't.
Yes.
But that would be sad if I would lose these women.
Yeah. Or it may require asking for extra data, which can be like, to put Kevin's question into context, right? It means going to the chiefs and figuring out. So we just might want to think about that piece.
That's really good to know. Yeah, absolutely.
Forgotten about that.
No, thank you.
Do you have any questions online?
Not any yet. Yes, Michael?
Thank you, that was very informative, and now I know what you're always doing. I have a slightly different question, and it's really my own nosiness, but I'm just wondering what got you interested in this topic, or what motivated you for this topic?
What motivated me in this topic? So I was doing my bachelor in Canada, coming newly as an international student from Germany, and I was hearing about people having C-sections a lot. That was new to me, and I was interested in medical sociology. I was taking all these kind of courses, so this topic of medical sociology was important to me, and so I tried to explore it further, and I was shocked to see how high the rates were, and I tried to find out why they might be so high at a time when I was way before wanting to have babies myself, but I just thought it was an important topic because the rates in a country like Canada were so very high. And then I actually found out that they're just as high in Germany, which I hadn't expected because there's a lot more midwives in Germany, and everything that we always praise in Canada as helping to reduce the rates is happening there, but the rates are just as high. They are localized high in certain spots and not as high in others. So this again is interesting to see that there's clearly differences in practice patterns. And so this has been a topic that I've been exploring throughout my master's and my PhD. And so since I've been collaborating with Claire on people living with HIV, I've been looking into what has been done on women living with HIV and their maternal health outcomes, and there wasn't much. We thought, why not marry the two topics together and find out. So this is where it came from. Thank you very much.
Okay, thank you, Esther.